To introduce the first speaker, and first speaker is Dr. Varsha De Soisa. Varsha is a senior lecturer in medicine at Faculty of Medicine, Ruhuna, and she is currently works as a consultant, honorary consultant physician with a special interest in geriatric medicine at Teaching Hospital, Karapitiya. Her talk for the day, titled as Sarcopenia, the Clinical Application. I would like to invite Varsha to deliver her speech.
Very good morning to all of you. Thank you, sir. Right. Sarcopenia is my talk for today. As you all know, sarcopenia is a progressive skeletal muscle disorder with adverse health outcome. Initially, this disorder is described only in elderly population. Although it is increasingly recognized in old age, it is not a disease confined to the older adult. During the next half an hour, I'm going to talk about the prevalence and effect of sarcopenia on aging, screening and assessment, differential diagnosis, and I'm going to go a little bit deeper on the non-pharmacological management of sarcopenia. Let's start with the case scenario. A 74-year-old man, retired teacher, admitted following a fall with head injury. But there was no loss of consciousness, urinary fecal incontinence or seizures associated with the fall. He described this incident as his legs were weak and they gave way while he was walking. He had many falls over the last 6 months, about 1 fall per month, but no loss of consciousness with any of these falls. He required support to stand up, following most of the falls. He felt tired and slept most of the time during the daytime and reluctant to go out and almost housebound. He had loss of appetite and lost about 4 kilograms over the last 6 months. He was on multiple medication, including medication for type 2 diabetes, hypertension, dyslipidemia, and benign prostatic hyperplasia. On examination, he was a thin-built man with a BMI of 19, pale, but no stigmata of other nutritional deficiency. His pulse rate is all right, 68 and regular, but there was a significant postural drop. With normal precordial examination and examination of his respiratory and abdomen were unremarkable. Neurological examination revealed a stocking type sensory loss, and there was wasting of his arm, thigh, and calf muscles. His hand grip strength was remarkably diminished. Joint examination revealed evidence of early osteoarthritic changes in bilateral knees, but preserved range of movements. So what are the probable causes of recurrent falls in this man? Is it polypharmacy, postural hypotension, or cardiac causes like arrhythmias, sensory motor neuropathy due to the advanced diabetes, osteoarthritis, frailty, sarcopenia? Let's get into our talk today. What is sarcopenia? So Rosenbeck defined sarcopenia in 1989 as loss of muscle mass. So it comes from a Greek word, like sars mean flesh, penia mean loss. So loss of flesh or loss of muscle mass. About 2 decades later, so sarcopenia is defined as not only loss of muscle mass, but also loss of muscle strength and physical performance. Now, this disorder is formally recognized as a muscle disease and is being included in the International Classification of Diseases since 2016. I want you all to pay attention to this diagram. This is a mid-thigh CT scan of 2 women in their 72 years with the same BMI of 25. Oops. Right. Okay. Yes. So the woman in the left hand side, the woman without sarcopenia, and the right hand side is working. All right. Okay. Right. the woman in the left-hand side is the woman without sarcopenia, and the right-hand side is the woman with sarcopenia. So you can see the woman without sarcopenia has a good muscle mass with less fat mass around it. And the woman with sarcopenia has relatively low muscle mass with increased fat mass. What will happen to you when you are aging? You tend to have reduced lean body mass and increased fat mass if you don't take measures to keep, maintain your the muscle mass. So this diagram further illustrates what will happen to your muscle mass with aging. It's the tale of three legs. So you can see the very muscular leg in the right hand, the left hand side. So this person can enjoy any kind of vigorous activities because he has a good volume of muscles like hiking, swimming, cycling without any problem. The one in the middle has relatively low muscle mass compared to the muscular leg, but still he can engage his activities of daily living without any problem, but he might have problem in engaging the vigorous activities. But compared to these two legs, one in the right hand has a very, relatively, very minimal muscle mass. So that person will have problem even attending to his activities of daily living. That is what will happen to your muscle mass with aging. So you will have a peak muscle mass by the age of 30, 35. After that, the muscle mass tend to decline at a rate of 8 to 10% per decade. Right? This will be further accelerate after the age of 70. Right. So moving from the muscle mass to muscle strength. So what will happen to the muscle strength with aging? These two diagrams illustrates what will happen to your muscle strength with aging. So one in the left is the muscle strength, how it's going to behave with aging for the males, and one for the right is for the female. So when you pay attention to the one for the male, you can see the muscle strength progressively increases up to the age of 30. Then it will plateau for another decade. So up to the age of 40, then it starts declining. And this decline will accelerates after the age of 60. So for the female, they start with a lower muscle strength, but the behavior is the same. So the muscle strength will be, they behave as same as for the male. The pattern is the same, but start with the lower muscle strength. Right. Sarcopenia, is it a rare condition? No, it is a very common condition in the clinical practice, especially in the elderly. So it is estimated that 25% of the people over the age of 65 suffer from some kind of sarcopenia, and 60% of the elderly population over the age of 80 suffer from some kind of sarcopenia. So the prevalence varied between 10 to 27% in a meta-analysis conducted in 2022 with a mean age of 70 years. The highest prevalence was observed in Oceania, and the lowest prevalence was observed in Europe. The global prevalence of severe sarcopenia range from 2% to 9%. What is our local situation? In Sri Lanka, prevalence of pre-sarcopenia, sarcopenia, and severe sarcopenia among post-menopausal women was 4%, 3%, and 1.2% respectively. The prevalence is higher in hospitalized older adults and the adults in nursing homes than community-dwelling older adults. Right. Sarcopenia is a vicious cycle. Why did I say so? When you are sarcopenic, you tend to have low muscle mass. So when you have low muscle mass, you will be easily fatigued when you engage in some kind of physical activity. So when you are fatigued, you tend to stop the physical activity prematurely, or you avoid any physical activity that gives you the fatigueness. So physical activity is the fuel for the muscle formation. No physical activity means there's no further lowering the muscle mass that in turn worsening the sarcopenia. So it is indeed a vicious cycle. Right. So there are two categories of sarcopenia. They are primary and secondary. So as I said earlier, the sarcopenia is an age-related condition. Right? That is called primary sarcopenia. But in some individuals, apart from aging process, we can identify other etiologies. as a cause for sarcopenia. Like it could be activity related, like, prolonged bed rest or sedentary lifestyle, or disease related, like advanced organ failure, inflammatory conditions, malignancy, endocrine diseases like androgen deficiency, growth hormone deficiency, and so on. And nutrition related like malnutrition, malabsorption, GI disorders, and so on. Right. So there's something called acute sarcopenia. So that is also very well described in elderly. So when an elderly person happen to be hospitalized for acute illness, and he has to be on the hospital for more than 10 days, so that it is estimated that they can they can lose their muscle mass by 6 to 10% within 10 days. Compared to the young adult who has been hospital for even 1 month, they will lose around only 2%. So the acute sarcopenia is a condition that has lasted less than 6 months. Right, so what's the impact of sarcopenia? Sarcopenia means low strength, low muscle strength, low power, low muscular endurance. So that means easy fatigability, less exercise tolerance, risk of falls and fractures, and you will have problem with engaging your activities of daily living, your poor quality of life. Not only that, not only the problem with the mobility, they will have adverse, the cardiovascular problem, the adverse cardiovascular event, respiratory event, and the immunity will go down, the increased risk of infection, hospitalization, poor recovery from infection, and post-operative procedures, and this linked to the cognition, so they will have a problem with cognitive impairment, increased cognitive impairment, and overall they will have the poor quality of life, life expectancy, and the increased mortality. So this diagram further illustrates the consequences of muscle loss. So there have been many groups working on sarcopenia. I have listed few leading groups here. The European Working Group of Sarcopenia for Older People, International Working Group of Sarcopenia, and Asian Working Group of Sarcopenia. The guideline and definition established by European Working Group of Sarcopenia for Older People are being currently used worldwide due to the easiness of its application. So in 2010, European Working Group of Sarcopenia for Older People published a sarcopenia definition. So that was widely used since then. But about a decade later, this working group met again to fill the gap in the definition of sarcopenia based on the scientific evidence accumulated since then. So what did they do? They revised the guideline they made in 2010. What's the revision? What's the main revision? They identified muscle strength as the key predictor of adverse outcome, rather over the muscle mass. So the muscle strength comes to the forefront, right? And also they updated the algorithm for sarcopenia. So based on 2018 operational definition, they identified 3 categories of sarcopenia. As you all know, they are the probable sarcopenia, confirmed sarcopenia, and severe sarcopenia based on 3 criteria. What are they? Criterion 1, low muscle strength. Criterion 2, low muscle quantity or quality. Criterion 3, low physical performance. Right. So if you have only the evidence of low muscle strength, that means the probable sarcopenia. So diagnosis is confirmed if you have the evidence of low muscle strength and the low muscle quantity or quality. That means criterion 1 and 2. If criterion 1, 2, and 3 are all met, the sarcopenia is considered severe. Right. So they updated the algorithm. So based on the case finding, assessment, confirmation, and severity determination. So the FACS model being formulated. So in a nutshell, this flow chart demonstrates the algorithm they updated in 2018. So start with the case finding. You can see here. So if you suspect clinically the patient has sarcopenia, clinical suspicion, or else you can screen with using SARC-F questionnaire. So if it is positive, that means that person need further assessment to determine whether the patient has low muscle strength. So there are certain measures we have to take to determine the low muscle strength. If it is low, there are evidence of low muscle strength, that is, then the sarcopenia is probable. Then we have to subject the person to confirm whether the patient has sarcopenia. So then we have to assess the person's muscle quantity or quality with there are certain investigation for that. So if it is also confirmed the patient has low muscle mass, then that means he meets the criterion 2 as well. So sarcopenia is confirmed. Then person is subjected to assessment of whether the patient has evidence of poor physical performance to assess the severity with certain tests. So if it's confirmed the patient has poor physical performance, that he meets the criterion 3 as well, that confirm the severe sarcopenia. So it's coming with case finding, assessment, that confirm the possible, leads to the diagnosis as probable sarcopenia, confirmation for the sarcopenia is confirmed, then the severity assessment. So let's start with the case finding. In clinical practice, case finding will start when the patient complains of symptoms and signs of sarcopenia. What are they? So they will complain of recurrent falls, feeling fatigue, easy fatigability, slow walking speed, difficulty rising from chair, weight loss, unexplained weight loss, muscle wasting. So that means that the patient has some, the features, clinical features suggestive of sarcopenia. In that case, the person needs further assessment. Or else we can use the Sarc-F questionnaire as a screening tool to screen the patient at risk of sarcopenia. So Sarc-F has a low to moderate sensitivity and very high specificity to identify and predict the low muscle strength. Right. So this is the Sarcopenia questionnaire. You can see there are 5 domains to detect the strength: the walk-in, the transferring from chair or bed, climbing, and falls. The score equal or greater than 4 is predictive of sarcopenia with poor outcome. Right. So if the patient is positive for Sarcopenia screening tool is positive, or the patient has symptoms and signs suggestive of sarcopenia, then that person need further assessment with a set of investigation or the test to confirm whether the patient has probable sarcopenia, the confirmed sarcopenia or severe sarcopenia. So these area of investigation the patient will subsequently subjected to. So we'll start with the assessment of muscle strength. So what are the things available to detect the low muscle strength? So we start with the hand grip strength determination. So low grip strength is a powerful predictor of poor patient outcome, like longer hospital stay, increased functional impairment, and so on. Because of its ease of use, the grip strength is advised for routine clinical practice. So how it is been assessed? Using a calibrated handheld dynamometer. When measurements on the hand grip is not possible, like a problem with the, if the patient has a problem with hand, like, the arthritic condition or a stroke. So then how can we measure the strength? Using the isometric torque methods can be used to measure the lower limb strength. And the other test is the chair stand test. To measure the muscle strength, the lower limb muscle strength, we measure the quadriceps strength. The patient is asked to rise from the standard chair 5 times, and without using his or her arms, and time taken for this is measured. Right, so moving from the muscle strength to the muscle mass or muscle quantity and quality determination. So this picture illustrates the DEXA scan, the DEXA scanner measuring the appendicular skeletal muscle mass. So DEXA scanner is widely used in the clinical practice as a non-invasive method of measuring the skeletal muscle mass. So then there are other measures to, the other measures are available to measure the muscle mass. They are the anthropometric measures, like, calf circumference, mid-arm circumference. However, these measures will also reflect the underlying nutritional status of the patient. So they are not very reliable measurements to measure the muscle mass. So moving from muscle strength to the muscle mass to the the measurement of physical performance. The physical performance has been defined as objectively measuring the whole body function related to the locomotion. So we'll start with the gait speed test. So gait speed test considered as a quick, safe and reliable test for sarcopenia and is widely used in practice. So gait speed has been shown to predict adverse outcome related to sarcopenia. The commonly used gait speed test is the 4-meter usual walking test, and the speed measured to the patient is asked to walk on this 4-meter and the speed is measured. And the other thing is the time up and go test. The person is asked to rise from the standard chair and walk on a 3-meter, the target on 3 meter ahead, and turn around and come back and sit down. So time taken for this will be measured. These two tests is widely used as a measure of measuring the physical performance. There's something called a short physical performance battery, again measuring the physical performance, measuring the balance, gait speed and chair stand test. The maximum score is 12, and in any score 8 or less considered indicate the poor physical performance. So these 3 tests can be used to measure the physical performance. So this this diagram shows you the sarcopenia diagnosis at a glance. Let's move to the differential diagnosis. What are the differential diagnoses of sarcopenia? They are mainly the cachexia and frailty. So, these are the main differences and similarity between sarcopenia and cachexia. So because of the interest of time, I'll skip this. And the frailty is the other differential diagnosis. This is the decline in bodily function in age, and it goes beyond the physical function to involve your mental and social function as well. So most frail patients have sarcopenia, but not all patients with sarcopenia are frail. Right, so there's something called sarcopenic obesity. What do you mean by sarcopenic obesity? So sarcopenia with excess weight and adiposity. So because of the patient has excess body fat as well as the patient has evidence of low muscle mass as well as the function. So it occurs when you consume a lot of calorie and at the same time no physical activity. So it poses a greater risk of health-related outcome, either more than the obesity alone or sarcopenia alone. So it has a greater risk of cardiovascular, the health outcome, adverse outcome, hypertension, diabetes, and dyslipidemia. What's the treatment? Both diet-induced weight loss and regular exercise. Moving to the management. So if you identify the cause for the sarcopenia as a secondary cause, you have to treat, and the physical activity. The more research, the research has shown again and again physical activity as the cornerstone in the treatment of the sarcopenia, and diet, and the pharmacological management. More research is, evidence is needed to make any kind of solid recommendation for pharmacological management. Moving to the physical activity. So as I said, the physical activity is the cornerstone in the management, the treatment and prevention of sarcopenia. So there are 2 kinds of exercise. They are the aerobics and your resistant training. Though the aerobic exercise can increase the number of mitochondria in the skeletal muscle, they are the powerhouses in the skeletal muscle, but it's really the strength training that has been shown as the powerful intervention that help prevention and treatment of sarcopenia. So the goal is with the strength training is to progressively overload the muscle to increase the muscle fiber size, number and function, so that leads to improved strength, power and endurance over the time. So there are few good news. When you are engaging in strength training, that may preserve lean body mass even though you are following the low-calorie diet to reduce body weight. If you just follow the low-calorie diet without engaging in strength training, what will happen? Yes, you will lose your body fat and body weight, but at the same time you will lose your muscle mass as well. And the other news is that strength-trained muscles have higher glucose uptake and lower insulin resistance, and leading to better glycemic control. Right, this is the exercise prescription, resistant exercise prescription in summary. So I'm going to skip that also because of the interest of time. So what will happen, you just engage in aerobic exercise only. So resistant training is less appealing to sedentary, doesn't it? So, is it not at all useful? No, it is also useful. Can cause increased muscle formation, skeletal muscle formation, and increase muscle fiber area, but it's cause less muscle hypertrophy. It can reduce the fat mass and reduce the body weight. It has a functional role, but it's not very effective in the treatment or prevention of sarcopenia. Right. So this diagram shows you the strength training in elderly. So it's the most powerful tool against sarcopenia. It reduces the inflammation more. It increases the body composition more, and reduces the insulin resistance more. Right. So there's a few words about nutrition. It is recommended that the elderly people with sarcopenia need increased protein intake for their better muscle strength, the strengthening their muscles and the increased formation. So it is recommended that 1 to 1.2 gram of protein per kg per day is recommended. That means averagely approximately 25 to 30 gram of protein per meal, and their calorie intake per day is 25 to 35 kilocalorie per kg per day. However, this should be tailor-made to the individual. And if they are deficient of micronutrient, it should be replaced. And these pharmacological agents, for a solid recommendation, they need more research evidence. And this diagram is a very good diagram. This graph shows the natural progression of muscle mass and strength with aging. So there's a huge individual variation can be observed here with regard to muscle mass and strength, especially in old age. To reduce sarcopenia in old age, we must get started early, right? So we have to aim achieving the maximum peak, take all the measures to keep, maintain the peak during adult life, and minimize the loss in old life to ensure good quality of life in old life. Right, in summary, so the sarcopenia is not a rare condition in clinical practice. There had been major attempt to integrate sarcopenia into clinical practice, so use the FACS concept. So there's an increased incidence of probable sarcopenia in our clinical practice and confirmed and severe sarcopenia in some setting. If you have identified the secondary cause as for the etiology for sarcopenia, you have to treat it. And resistant training is the key intervention in prevention and treatment of sarcopenia. Thank you.
Thank you, Dr. Varsha, for that excellent presentation. Any questions from the physical audience here? Yes.
Yeah. Thank you, Varsha. Since there's a lot of trainees as well, with regards to walking speed and get up and go tests, the cutoff limits, if you are doing it at bedside, probably if you can tell about any cutoffs for...
All right, okay.
Yeah. Thank you.
So gait speed test.
And gait speed and get up and go test. Yeah.
Get up and go test. Right, okay. So I have not included the limits. So actually I can't remember the exact, the cutoff for to diagnose the poor physical performance. So I'm sorry, I can't answer that question. Yes, it's varied with the age, yes. So for the 60 to 70, there's a cutoff, 70 to 80, and more than 80, there's another cutoff. You need not to buy hard, they are there. You just
I think somebody is taking the 10 seconds to do the tug test, TUG tug test, that would be considered as a positive thing and screening for frailty. So, yeah.
Right.
Yeah, we need at the bedside to keep that
As a screening,
yeah,
okay.
cutoff. Thanks.
Also a comment, I think we spoke of nutrition. You spoke of the high protein intake, which is essential, but in particular, nutrition, particularly the proteins which have leucine, is proven to be the building block of muscles. So I think what people advocate is, I mean, there's the market, they talk of giving whey proteins, etc. But not all can afford. But there are definitely dairy products, especially the curd and whatever, and then also certain pulses and cereals like chickpeas and green gram, etc. I mean, for this region, that's what they advocate. So, if somebody is vegetarian, definitely.
Yes.
Varsha, just one question as a rehabilitation, doing the rehabilitation in this country. A person generally, as you said, that they can go into severe sarcopenia soon after infection, and that sort of recovery takes a long time. So, do you recommend them to be in a inward sort of institutional rehabilitation for them? Will they tolerate that? Generally, what will happen is if you are in institution, we generally use the full time rehabilitation. They go for morning and evening and that sort of thing. This age with these problems, will they tolerate that, or will they do better from home, maybe coming every other day, something like that?
It's depending on the patient's home, the support, the at home. So the thing is that, for the time being, when they recovered from the acute infection or acute insult, we tend to discharge the patient without looking into their functional status. So they will go down, downwards, after that. So yes, so it depends whether the patient can come as outpatient and get the rehabilitation done, or as institutional level rehabilitations depend on the patient's family support. So, and the level of the disability, sir. So it should be individualized.
Okay. In absence of any further question, thank you, Dr. Varsha, for that presentation, and we'll be sharing our certificates at the end of the program. So I'll hand over to Barana to introduce our next speaker.
Thank you, Varsha. So our next speaker is Dr. Joanna Davis. Actually, she is joining online, but